Hello and welcome to Season 2 of the Here For You podcast. If you're new to the Here For You podcast, thank you for joining. This podcast explores themes of therapy, psychology and philosophy and looks at the sort of intersections between those different disciplines. If you've listened to the podcast before, welcome back. I hope you enjoy Season 2. In today's episode, we're going to be exploring Sanism, which is the impact of mental health discrimination. And do stick around to the end of the show for a update of what to expect in Season 2 and some of the things that I'll be doing with the podcast over the next couple of episodes. Okay, so jumping straight into sanism, and I think really before we can talk about what sanism is, I think it's worth us exploring a little bit about what it means to be insane. And, of course, I appreciate that the word insane is old language, but if we're going to talk about what it is to be sane or sanism, then I think we need to look a little bit about what it means to be insane, at least from a traditional standpoint. So a dictionary definition of being insane or insanity is that to be insane is a condition of being mentally unsound, especially when serious enough to keep a person from being convicted of a crime or from performing duties required by law. This was in the Merriam-Webster dictionary. Like I said earlier, it's not broadly used anymore, and I think it's often replaced these days, probably most commonly with the term mentally ill, although that probably has some problems with it as well, which we'll get into later on. Some examples of what was traditionally considered to be insane or even sort of mentally ill these days would probably be things from the DSM, which is the Diagnostic and Statistical Manual, which is the tool used to diagnose mental illness within the US. In the UK, just like with a lot of other countries, we use the ICD-11 mostly to diagnose mental health conditions. But from the DSM, probably things that would typically be associated with insanity and being mentally ill are things like schizophrenia, bipolar, depression, anxiety, just to name a few. It's a very big document, the DSM. This gets a little tricky, I think, when we start to take a longer view of looking back in history, and we start to kind of look at possible diagnoses that used to be in the DSM previously. For example, within the DSM-1, which is in 1956, homosexuality was classified as a mental illness according to the DSM. It was classified under sexual deviation, which was in the larger section of sociopathic personality disturbances within personality disorders. So I think this sort of highlights that the definition of what we would term mentally ill has changed substantially over time periods, even within the tools in which we use to diagnose these things. And it kind of makes me think anyway about what diagnoses that we are currently using in the current version of the DSM as well as the ICD that in 50 years' time we will think were barbaric, that we were diagnosing that as a form of illness. So when it comes to being labelled as mentally ill or being labelled as insane, some of the unique challenges that this may present for people are things like travel restrictions. Often, or in some cases, when somebody has a mental health diagnosis, depending on what it is, that may raise challenges for getting visas in certain countries, and therefore being able to travel completely freely within the world. There can also be the removal of children within the context of social services involvement. This would be when there is a consideration of risk to those children, but parents having a diagnosable mental health condition may be contributing evidence to causing the removal of children from people's care. And as well as that, both in the context of child removal or social services involvement, any other sort of risk assessment process within a healthcare setting or within a forensic or legal context. A lot of the key risk assessment tools that are used to assess violence risk or risk of a possible self-harm will consider a diagnosis of a mental illness as a key factor to be aware of that may increase somebody's risk. So some very unique challenges with people who have a diagnosis of any sort of mental illness. Not only this, but on the more extreme end of the sort of spectrum, within the UK, the Mental Health Act of 1983, there's various sections. Probably most prominently is Section 3, which is a treatment order. This allows for the detention of a person against their will, possibly, for treatment within a hospital setting. This can be up to 6 months within a detention of a hospital. It can be appealed at a tribunal any time within that sort of 6 months, but after the 6 months are up, that person needs to be reviewed by a psychiatrist and either released from their section or it has to be renewed for a further 6 months. After 2 years of 6 months renewals, then the renewal process can go to every 12 months. Now, of course, people who end up being sectioned under the Mental Health Act form a minority of people who have a mental health diagnosis. However, it does present a unique challenge for people who have that diagnosis. And part of being sectioned within a hospital setting may involve enforced treatment. So this could be enforced treatment through the use of medication, so medical intervention, as well as other sort of procedures such as ECT, which is electroconvulsive therapy, if it is deemed to be of within the person's best interests and they are deemed not to be able to consent to what is best for their welfare, then treatment can be enforced and under this context. Again, this is a minority of people with a diagnosis of mental health illness. However, it does present as a arguably very unique context in which people find themselves in who have a mental health diagnosis. And this is just scratching the surface, really, of the Mental Health Act and the use of enforced treatment and sectioning within the current system within the UK. There's also lots of other versions of that. There's sections that interact both with a hospital order as well as the criminal justice system. I don't have scope to go into that in this podcast today, but I will leave some references to further reading if people are interested in finding out more about the various different sections and types of enforced treatment that people may be involved with if they are deemed to lack capacity and need for treatment. Okay, so the flip side of that, we looked a little bit about what is insanity, which I guess more commonly these days is called mental illness. But what is sanity then? And the dictionary definition within the Oxford Languages Dictionary is to be sane is to be of sound mind, so not mentally ill. Also kind of termed as reasonable or sensible. There is variations across culture and time, so what is considered to be sane at one time and place may not be considered sane in another. In this way, perhaps sanity is best defined as a person who lives, behaves, thinks, and feels within the bounds of current social norms. So this leads to the idea that someone who is insane or who is sane would be easy to identify from someone who is insane or sane, so that these things are easily identifiable, that one could go out into the world and easily identify somebody who is sane versus somebody who is insane. just like somebody who is, I guess, mentally ill or mentally well, possibly. However, I think this is not as clear-cut as we would perhaps like to believe it is. Some examples of this, a very famous psychological experiment by Rosenhan in 1973 called Sane in Insane Places. I will try and leave a link down to that study in the show notes. But in this study, Rosenhan very briefly took a selection of participants and got them to go to their general practitioner and say to their general practitioner that they were hearing certain voices, and they weren't actually hearing those experiences, but they were told to go and say that they were hearing voices, to command hallucinations, in which case a percentage of those people ended up going into mental health institutions. And the instructions of the experiment were to, once they were in a mental health institution, to stop all symptoms and ask to leave as soon as possible. And I think the longest that anybody stayed in there was 6 months. And a lot of the behavior that people were engaging with was, in later reflection, deemed to be evidence of their insanity. So, for example, people making notes in a communal area about how they were feeling, or making notes around what they were doing, was deemed to be indicative of paranoia, for example. So when this research was released, I think it was the American Psychological Society or Psychiatric Society, I think, wrote to Rosenhan and said, okay, you know, this isn't valid research. We didn't know that you guys were coming. If you send a selection of your stooges, we will pick them out. Give us a year and we will pick out everybody that you send as a stooge, to sort of prove that actually we can definitely distinguish people from who are sane versus insane, and people who are faking insanity, as it were. So he said, yeah, okay, yeah, I'll do that. I'll send some people, and at the end of the year, you tell me who I sent, what people I sent. So they wrote back to him after a year and said, okay, these are the people that we've identified as stooges. And he wrote back and said, I didn't send anybody. So again, sort of reinforcing his novelty, but novelty reinforcing his idea that the people who were diagnosing some of these conditions couldn't distinguish people who had them versus people who didn't. Of course, this study was in 1973, so quite dated now. One would definitely hope that things have changed since that time. But also, I think another challenge to this idea of what sanity is that an estimated 38% of the general population have experience with visual hallucinations, and that this is outside of these hallucinations being drug-induced. So these are just hallucinations that are experienced by people, everyday people on a day-to-day life, and not associated with any mental illness or with any sort of drug-induced phenomenon. Up to 38%, that is. It's in a study in 2022 by Ainsworth et al. And I think this challenges, I think, our conception of what we consider to be sane and insane. Particularly, I think a large proportion of the population may view seeing things that aren't there, such as hallucinations, visual, auditory, as clear evidence of somebody who has lost touch with reality and therefore may be deemed to be insane. And I think this heightened figure of 38% kind of possibly draws some of that into question. So I guess all this is to say that perhaps the distinction between sanity and insanity is not as clear-cut as we might like to believe it is. Okay, so with all that in mind, what is sanism? Okay, so sanism is an irrational prejudice against people with mental illness and or people who differ from a perceived psychological norm. Just like other isms, Sanism is based largely upon stereotype, myth, superstition, and de-individualization. A lot of the research into this area has been conducted by a legal scholar called Michael Perlin, who has done extensive research into and argumentation into the impact that Sanism has legally on people's rights. It's probably best understood that Sanism goes deep. The roots of this go very deep. I think we could probably trace this back to things like mental illness, having previously been viewed as a sin, as sort of evil spirits within somebody, previously, I guess, in some context being viewed as criminal or illegal. And I think arguably we could even sort of see the roots of Sanism in our current society related to this idea of mental illness being classified as an illness, right? Being classified as a biological illness. That there may be impacts of that impacts upon people's perception of people who are deemed to be sane or insane. There's other terms that have been used other than sanism to describe this same sort of prejudice against people who differ from a perceived psychological norm. Some of these terms are mentalism, some of these terms are sane chauvinism, and also psychophobia. So these are, I guess, interchangeable concepts with sanism to help us understand some of the discrimination that these people may uniquely experience. And I think it's probably fair to say that there is probably a lot of transsectionality within sanism and other isms, racism, sexism, homophobia, and other identities as well that we probably want to consider as increasingly impactful on people's lives. Outside of the sort of similar terms to sanism, I think there are concepts that are related to sanism, although differ subtly. So they may be within the same family as sanism, but more related rather than exactly the same thing. One of these concepts is psychocentrism, which is the view of problems as the view of problems as pathologies rooted in the mind and or body of the pathological individual rather than a product of social problems. So I guess this is the idea that what psychocentrism is saying here is that the problems that people face, the expression of psychological abnormality is based purely off of somebody's individual characteristics rather than as a response to the social situation, and perhaps a very understandable response to the social injustices and context that they may find themselves in. Another related concept is epistemic injustice. This is something that we've touched on in the podcast before in different ways. I imagine that at some point I'll do a whole episode on epistemic injustice and mental health. It's a very big field in itself, but epistemic injustice is a concept developed initially by Fricker in 2007 from the world of philosophy, and it describes the harm done to people in their capacity as knowers, often sort of split into two different subcategories of epistemic injustice, which is testimonial injustice and hermeneutical injustice. I won't get into those too much here, other than to say that epistemic injustice is a big thing that I would argue really impacts uniquely people who find themselves in interactions with the mental health care system. And I will talk more about that in a future podcast, as well as previous episodes of the podcast have touched on the topic of epistemic injustice. Another sort of related movement or concept is the idea of the MAD movement or MAD movements, which is a series of social movements which are aiming at sort of reclaiming identities and discourses around how people talk about being mentally ill or insane. And yeah, again, trying to reclaim that word mad for people who actually have had the lived experience of I guess, psychological experiences that differ from the perceived norm. There's also a lot of movement within anti-psychiatry and critical psychiatry. This is a movement it's been going on for a long time now, and really predominantly amongst psychiatrists themselves, which is, I guess, anti-psychiatry and critical psychiatry is somewhat of an umbrella term to describe lots of different practitioners and ways of thinking about psychiatry. Critically, where people might not agree with each other, but perhaps broadly speaking, under the umbrella of anti-psychiatry is the concept that psychiatric treatment is possibly, in some ways, is possibly causing more damage to people than is actually being helpful. Particularly, perhaps, the use of very strong antipsychotic medication. Arguments on both sides of that spectrum, and again, perhaps future episode of the podcast will explore anti-psychiatry and critical psychiatry and sort of weigh up the debates for both sides of that way of thinking. Okay, so explored a little bit about what Sanism is, as well as the various related concepts that help us to understand that concept even further, as well as understand the world of Sanism. But now we're going to look at a little bit more about the possible harm done by Sanism. One of which I think we've already touched on a little bit, which is epistemic injustice. So people diagnosed with mental illness are denied the status of knowers. This can be both implicitly through the devaluing of testimony, as well as explicitly through the questioning of capacity. There can be a denied adequate legal representation. This can partly be related to the concept of seeking an insanity plea. There may be a perceived stigma around people putting on mental illness as a way of seeking a lesser sentence within a criminal justice system, and therefore not being responded to via their actual needs and having adequate legal representation because of the stigma around people doing that. And then that can be from a legal perspective, as well as from a wider sort of social lens of how insanity and the criminal justice system interact with each other. That's a big area. I think that is quite interesting way in which sanism can be harmful. Of course, like with any other ism, there's aspects of dehumanization and de-individualization of people. So this idea of seeing people who are mentally ill as less than, or less than human, less than individuals, and therefore worthy of less treatment or less rights even. Another sort of area is loss of work. So people who have had a diagnosis of mental illness have often reported challenges with finding employment, particularly after having had periods of possible admission, and trying to find both employment in terms of being employed by others, but also then having an employer who understands the possible reasonable adjustments that maybe need to be made for people who have certain diagnoses or certain experiences that may not support a traditional model of working. Of course, there's a lot of loss of friendships and romantic relationships within that can be a direct result of sort of sanism, and this could be both through the context of people losing friends when they have a diagnosis, but also people losing the possibility of friendship and romantic relationships because they have a certain diagnosis. And I think this can be a really tricky one, right? Because I think this can further reinforce some of the challenges that people may have found themselves in the first place that led them to experience a form of distress leading to a mental health diagnosis. The lack of contact with other people, possibly because they have a diagnosis, may further reinforce the the cycle of distress that somebody finds themselves in. There can be denial of services for people with a diagnosis, in particular stuff like adoption. A lot of people can struggle. Adoption is very tricky anyway, for people, but if somebody has a diagnosis of mental illness, this may, in some countries, in some contexts, be a barrier to people adopting children. And I think perhaps what all of this speaks to, all of these different harms, is the wider harm of people being seen only as their diagnosis. So people being seen as only schizophrenic or only depressed, rather than a person who happens to have that diagnosis. And I think that's probably the core of what Sanism entails, is people just being seen just as that thing, only as that thing, and then that thing being seen as wholly negative and wholly in need of avoidance. So with this in mind, how might we tackle Sanism? How might we look at readdressing some of these harms that may be done through Sanism within society? So perhaps one of the ways that we might be able to do this is through open discussions within society about the existence of Sanism. So I guess just naming it is probably the first step in tackling some of the harm that's sort of caused. It's just acknowledging and speaking about such an existence within discourse, wider in society, but also within individual conversations that people have. Becoming more aware of the language that we use when we're talking to kind of others. So stuff that is commonly used within everyday conversation is stuff like, oh, that's insane, or wow, that's crazy that happened. And not that that's problematic in itself necessarily, but you could see how that may lead somebody to feel excluded in their experience. Just the very common use of words like that. Just like with any other ism, a way of tackling some of the harm could be outwardly challenging sort of sanist behaviour. So if somebody is acting in a very sanist way, or possibly causing harm to somebody who has such a diagnosis, sort of gently and empathetically challenging that type of behaviour, and then possibly that could be through education as well. In a wider context, perhaps bringing lived experience into the centre of mental health discussion at both a social and a legislative level. And the importance of this is that it's not just in a tokenistic way, so the use of people are experts by experiences, but often what can happen sometimes within services, particularly mental health services, the use of experts by experiences can sometimes feel slightly tokenistic, in the sense of they are involved at one level of participation within the way that system functions. So there'll be often volunteers who will come in for, I don't know, half of a day of a training course and give a bit of a talk about their personal experiences. However, perhaps for lived experience practitioners and experts by experience to be fully impactful as they can be, their participation probably needs to be encouraged at every level of a healthcare organization, right up to kind of central leadership. If we can kind of get the sort of involvement in that capacity, it would probably go quite a long way to tackling the harm caused by sanism. Stuff like critical scholarship is important as well. So people, I guess, being critical of the stuff that they're reading and taking a perspective of sanism from it. Addressing and challenging the perceived norm of sanity within society, as we're kind of talking about earlier, the idea of what is considered sane seems at least minimally socially defined, and based off of what is considered to be psychologically normal at a given time and place. And I think if we start to challenge this may help with tackling some of the harm done by sanism. Something else that I personally would advocate for is a distress-based model rather than a symptoms-based model of understanding people's challenges. So this idea of rather than diagnosing or understanding mental illness based off of a symptomology, rather basing our understanding and our treatment based off distress. So, rather than, this person has these symptoms and we need to eradicate those symptoms, maybe more, how much distress is this person in, or how much distress are they causing others possibly, and is there a way in which we can work towards working with that distress rather than working with the reduction of symptoms. So just a conclusion to draw everything we've spoken about today together. So what is considered as sanity or insanity changes across cultures and times. Despite this, those that are classified as insane or mentally ill face a series of challenges that are completely unique to any other population in our current society. This, as well as other factors, leads to the experience of sanism within society. Sanism describes an irrational prejudice against people with mental illness and or people who differ from a perceived psychological norm. This may lead to several forms of harm to people who are considered mentally ill / differ from the psychological norm. Several ways of addressing this may include creating open discussion around sanism and moving towards a distress-based model of care. So that brings our discussion today in this episode of the podcast to a close. Within the season 2 of the Here For You podcast, some of the things that I'm going to be moving towards in the next couple of episodes is a mini series of a breakdown of the different therapeutic approaches, and this will be a very broad, very introductory discussion around this. No doubt I will miss lots of different therapeutic approaches, but the aim is to create something like maybe 3 or 4 episodes of a mini-series describing the different therapeutic approaches in psychotherapy, counselling, psychology, just as a sort of general introduction. So stay tuned for the first episode of that over the next couple of weeks. Thank you for joining the podcast today. If you'd like to support the show, do find us on Patreon, or find us on Buy Me a Coffee. The links to these websites will be in the show notes below, and please do like, subscribe, and continue listening. Thank you for listening today. See you again.